this is risk tolerance. This all comes down to risk
Yes.
tolerance. And I had a colleague who was talking to me about a patient, and she said this poor woman, I mean, this is just an example so people understand. This poor woman, her vaginal tissue was so severely atrophied. She was not sleeping. She's estrogen positive breast cancer history. She was not sleeping. She hadn't slept in a decade. She was in hell. Her marriage was in hell. Her husband and she were starting to consider living apart. I mean, everything was falling apart for
Yes.
her.
I hear these stories all the
Her
time.
musculoskeletal situation was a wreck, and she was like, everything was tearing constantly. And I said, hey, you know what? Here's some data. I sent her every study I could get my hands on. I said, talk to her doc and just see if he would consider. And after it was all said and done, her doctor agreed to give her a little bit of estrogen, and she was sleep. And it was a it was just risk tolerance. Like you said, shared decision making. She
Mhm.
knew the risks, but the risk of not being able to exercise, having your joints fall apart, running the risk of getting, I mean, we can talk about what happens to the poor vagina and the risk that they run with UTIs and with death, all the things, right? And she's back sleeping in the bed with her husband again. And
Yeah.
like the risk of obesity, not exercising, not sleeping, like what does that do to your cancer risk, right? Like these are
Well,
huge factors when it comes to
these are
cancer risk.
huge factors. I love that point. It's so important. We know that metabolic health, in terms of insulin resistance, metabolic syndrome, the risk of diabetes, the risk of visceral fat accumulation, the risk of chronic insomnia. I will tell you personally, one of the hardest things for me during my abrupt, prolonged premature menopause was the lack of sleep. Okay. I don't think I slept well for over 20 years.
Mm.
And it really impacted me, right? Luckily, I think I was doing enough healthy behaviors that I somehow muddled through it, but it was not easy. And it wasn't until many years later, and I'm very open about this, I made the decision, and it took me a long, long time to make this decision, that I decided, a number of years ago, to start the lowest amount of a transdermal estrogen patch and some progesterone at bedtime, and I became consistent. I took my own advice and became consistent with vaginal estrogen, and it changed my life, and I feel much better. And I've learned how to, um, you know, talk to patients about that, but also sometimes offer parts of that for patients, right? Getting to the point of like, all right, we're gonna pick one thing and we're gonna work on it, okay? And some people have a lower risk tolerance. Some people have a higher risk tolerance. Some people psychologically can't even consider
Yeah.
the thought of ever considering it. And you know what? That's okay, because I promise her I can help her. We can manage. We're lucky. There are non-hormonals out there, and we don't have to get all into them. But the Menopause Society has a really beautiful practice statement on all of the evidence-based non-hormonal medications, and it's not just SSRIs now. Oxybutynin, gabapentin, we've got fezolinean. There's a new one coming out on the market, right? So those can be useful, right? Are they perfect? Absolutely not. Can they be useful? Absolutely.
Mm-hmm.
Nutrition and exercise as medicine, I honestly look back and it is actually shameful that our medical system, but I don't blame the doctors. It's really the way the system is. The prescription for exercise and nutrition should have been as important as my prescription for my tamoxifen, but I had no support on that. And yes, I'm a doctor. I could have figured it out. But when I look back, I didn't do the right things, or I didn't even have the support around the right things. They
Mm-hmm.
seem like extras that are hard to like figure out, but that should have been part of it. Um, and so, I think I'm always like very careful about wanting to make sure we always bring that back in, because I don't want any breast cancer survivor to think, if they choose not to ever consider hormone therapy after breast cancer, or if they're really not a good candidate for it because they've got to stay on their aromatase inhibitor, or they're at very high risk of recurrence, and we're concerned about that. I don't want them to feel that all's lost. So patients say to me, but Dr. Mann, what about my cardiovascular risk and my dementia risk? I said, well, yes, of course, estrogen can be helpful when we start it earlier for that, right? And we know that can be beneficial, but I don't want anyone to ever think that if they can't take systemic estrogen, it means that it's all lost. And I
Right.
say, heart health is brain health, right? So whatever we can do to keep your cardiovascular system healthy, and sleep health, right, is overall health, right? So we have to focus on that, right? Um, And this is why sometimes, when I present to patients and even a medical oncologist, like this concept of hormone therapy, like I think people think that it's like high doses of hormones, right? And when I say, okay, let's just think about this, a 0.025 patch raises an estrogen level in the serum. If you look at the package insert from the pharmaceutical company, right, a 0.025 patch will get your serum level up to about 25, maybe 30, if we're lucky, picograms per ml. All right. When you have your normal menstrual cycles, your estrogen levels goes all the way up to 400, 500, even higher every single month. So we're not talking about and for many women who have been estrogen deprived for a long time, giving them back like very small
Yeah, just a
amounts
touch.
relieves a little bit of suffering. Sometimes, we'll consider just progesterone only.
Mhm.
A nightly dose of progesterone we have some data that it can help with night sweats and some hot flashes, and it does help with anxiety and sleep.
Mhm.
So sometimes that's something kind of that we can start with, if we've tried other things that are not helping with sleep, because sleep, if you don't sleep, I don't care what else we tell a woman to do. It's just impossible. Like you can't exercise or do, or function in a relationship or function at work, right? So
It's hell.
those are like, yeah, it's hell. So like low doses, and then kind of really, really hammering home how important local vaginal estrogen is. And then the testosterone questions, the other question I always get asked. And I think, we have way less data on testosterone after breast cancer, but we can also take like logic and available data that's out there. And, testosterone, when given in physiologic levels to get a woman within the higher range of a physiologic level for a woman, there's no data out there on earth that suggests that it raises breast cancer risk. We don't have much data studying testosterone in breast cancer survivors, but we also know that lowering it to sub levels isn't a targeted treatment. So do I think it's an option for breast cancer patients? Yeah, I think with shared decision making it is. And we have to remember a lot of breast cancer patients have lost their ovaries. So their testosterone levels are already in the tank because your ovaries produce about 50% of testosterone. We desperately need more data in all of these things. But when a patient is told we can't do it because we don't have perfect data, I say she doesn't have time, because that data is not going to be here in the next 20 years because no one's doing it. There are no ongoing randomized controlled studies looking at this question, unfortunately, except, and I want to talk about Duov with you because I think this is really exciting and interesting news for breast cancer patients out there. So if you want to, we
Yeah.
can
Yeah, yeah.
we can talk about that. So the American Society of Clinical Oncology annual meeting just presented the preliminary reports from the PROMISE trial. So the PROMISE trial it's a multi-center trial in Northwestern, other major centers throughout the US. And basically the PROMISE trial was looking at newly diagnosed DCIS, ER positive DCIS patients, okay? And they were given Duov. Duov is the brand name of conjugated equine estrogen and basodoxifene, right? So it's a combination hormone therapy that has been FDA approved for well over a decade, and it's FDA approved for hot flashes, night sweats, and preventing osteoporosis. So standard fare hormone therapy, right? But researchers knew that basodoxifene in Duov functions, it's a SERM, it's selective estrogen receptor modulator. I like to tell patients it's a fancy cousin of tamoxifen. So it blocks the estrogen receptors in the breast tissue and it blocks estrogen receptors in the uterine tissue. And it also degrades the estrogen receptor in breast and uterine tissue. So it's very profound, the impact.